Bismillah ar-Rahman ar-Rahim. Hello, my friends and my colleagues and my fans everywhere. I hope that everybody is doing well and feeling safe and peaceful. I will continue talking about the what we call, which is related to my presentation and my live video about seizure disorders. I want to speak about an important issue related to this topic, which is pseudo-seizures. I already talked about seizures. What are pseudo-seizures? Pseudo-seizures, they are clinical manifestations which might simulate true seizures, but they are not having the same pathogenesis, that there is no real sudden uncontrolled electrical disturbance or abnormal electrical activity within the brain, which is the underlying pathophysiology or pathobiology of the seizure itself, the abnormal electrical activity. So they might clinically look like seizure, but physiologically or pathophysiologically or pathobiologically they are not real seizures. What is this differential diagnosis of seizures, or what is the pseudo-seizures? Pseudo-seizures, they are sometimes called psychogenic non-epileptic seizures, psychogenic non-epileptic, because they are not real epilepsy, not real seizures. There is no real disturbance in the electricity, and they are usually or almost always due to some problem in the psyche. They are of psychic origin, of mental origin. And these psychogenic pseudo-seizures or psychogenic seizures or pseudo-seizures or non-epileptic seizures, not real epileptic seizures, they might be one of the following. Number one, in patients with mood or personality disorders. Mood or personality disorders, they might simulate real seizures, and they are one of the causes of pseudo-seizures. Number two, what we call post-traumatic stress disorder. Post-traumatic stress disorder, and this also a disorder following physical trauma or psychic trauma, and they have a wide spectrum of psychosomatic manifestations. One of them is pseudo-seizures, so post-traumatic stress disorder. Number three, in patients with dissociative disorders, especially what we call them in the past hysterical dissociation. And in some conversion, hysterical conversions can present with pseudo-seizure also, so hysterical cases. Also, patients with anxiety, they might present with pseudo-seizures. Patients with depressive illness or mixed depression and anxiety. Patients under stress. Patients with family conflict or family stress. When there is some sort of family problems or conflict, they might present with something looking like seizure, but it's not real seizure, it is pseudo-seizure, so family conflict. Number seven is also post-traumatic or post-physical injury. They might present with this what we call post-traumatic brain injury or post-traumatic brain disease. Might also present with pseudo-seizures. Chronic stress with acute stressful situations, especially social situations or personal situations, they might also present with pseudo-seizures. This is the all are under the heading of psychogenic non-epileptic seizures or pseudo-seizures. This is one issue or one topic in the differential diagnosis of real seizures and epileptic seizures. What are the other causes which is not epileptic, and they at the same time they are not also seizures? Because as I mentioned before, seizures might be epileptic or non-epileptic. What is the other differential diagnostics of seizures which are not epileptic seizures and which are not pseudo-seizures? Or they might also fall under the heading of pseudo-seizures by its broad its broad meaning, apart from being psychogenic. We should consider also in the clinical instance which might simulate, especially patients who present with loss of consciousness, What is the possible other clinical differentials. We have to mention hypoglycemia is an important differential, which might also simulate seizure, but it's not a real seizure. It is hypoglycemia because the pathogenesis of the loss of consciousness or the convulsion is different. They might present with loss of consciousness, same like seizure. They might present with convulsion, same like convulsive seizure, but they are not real seizures. It is hypoglycemia. Hypoglycemia is a common clinical entity which might look like seizure, but it's not a real seizure. Also, patients with syncope, because syncope might be confused with atonic seizures or akinetic seizures. But the pathogenesis is different. Syncope is transient loss of consciousness due to transient hypoperfusion, hypotension, hypoperfusion of the cerebral circulation or cerebral hypoperfusion, which lasts for few minutes, from which the patient recovers completely. Whether it is due to cardiovascular causes or neurogenic syncope or syncope due to other causes. So syncope is one of the differentials of seizures, but it's not a seizure. So syncope or syncope. Another possibility also is patients with hysteria. I mentioned this in psychogenic. Hysteria might look like a seizure, but it's not epilepsy and it's not a seizure. Hysteria, it is psychogenic. And I mentioned them in pseudoseizures. Also, patients with transient global amnesia, which is a state affecting the brain, and the patient might look like having absent, looks absent. There is disturbance in the awareness, there is disturbance in the orientation, and the patient looks like being unconscious, but it is a disturbance of the brain and cerebral condition. It's called the transient global amnesia, or TGA. It's one also of the differentials of epilepsy and of seizure disorders, but the pathogenesis is different. Most important here is the pathogenesis is different, although clinically or phenotypically it looks like a seizure, but clinically, but pathogenetically or pathogenesis and pathobiology, it is not a seizure. It's not abnormality in the electrical activity in the brain or electrical disturbance of the neurons. These are all conditions which might, which we might consider it in the differential diagnosis of seizures or epilepsy. The clinician should be aware of such conditions when he is met with a patient presenting with loss of consciousness or convulsions, or a transient problem in behavior or in sensations or in movement or in psychological phenomena or in feelings. These all clinical entities which I mentioned fall into the differential diagnosis. So the clinician should be aware, the clinician should be careful in analyzing the case in order to reach to the proper diagnosis and so to the proper management of the case. Thank you so much, and I wish all of you a happy, peaceful day, and God bless all of you. Salam.